Start.
Do you see it now? Okay, good. I was just trying to put it in the power presentation mode. Do you see it in a presentation mode?
Yeah. It is visual.
Okay, great.
Start.
Thank you very much, Dr. Rajesh. I enjoyed the presentation of Dr. Gopal. I actually asked the question because I'm fascinated with the C20C dynamic, and I try to make use of it. But I rarely make a sole decision on this value. And rarely there is anything published on neonatal ventilators C20C dynamic. So I wanted Dr. Gopal and your opinion on that. But I'm very honored to present this topic, and hopefully you will have some new insights. It's my pleasure to be with this group. Today, my topic will be it's a workshop topic on PPHN in units. I have no conflict of interest related to this presentation. Hopefully by the end of the presentation, these objectives will be covered. As we all know, PPHN is a very challenging condition in the intensive care unit. Two, maybe more in some areas, out of 1,000 live births develop this condition, and it represents 10% of babies who have hypoxic respiratory failure, and it manifests mainly due to impaired oxygenations. Mortality can vary, usually about 7 to 8%. But it varies really on the availability of nitric oxide and the type of the NICU setup. It can lead to complications, especially chronic lung disease, hearing loss, neurodevelopmental impairment, and it's a very challenging condition, and it represents a huge amount of stress on the physician and the family having their baby in the intensive care unit being sick. Just back to the basics, as we all know, blood comes from the placenta, goes directly to the left side of the heart through the PFO, and this oxygenated blood then get pumped into the aorta and reach the brain and the upper body. And while the blood coming back from the head and neck goes, which is deoxygenated, goes through the pulmonary artery, then redirected through the ductus arteriosus into the lower part of the body and back to the placenta to get oxygenated. This is important. The blood that goes into the lung, it's a small amount. In lambs, maybe 5 to 7 or 10%. In neonates and fetuses is a little bit more. After birth, the establishment of the pulmonary blood flow dramatically improves after ventilation and initiation of a lung aeration, either through ventilation or spontaneous breathing. As you see on this graph, the fascinating work done by Dr. Hooper and group, the pulmonary blood flow increased exponentially, at least 10-folds from its baseline oscillations during fetal life. We have to work on that, and I think we all recognize this part of transition, and a great deal of understanding this will help us improve our outcomes and our baby's health in the intensive care unit. What increases the QP or the pulmonary blood flow, actually lung aeration, as we discussed. This causes mechanical distension and facilitates the vasodilation of the pulmonary vascular bed. Oxygen itself, as we all know, the fetus is in a relatively hypoxemic environment, and this room air it presents hyperoxic environment relative. This fraction will change and increase the release of the nitric oxide synthase, and prostaglandin activity within the endothelial cells of the pulmonary vascular bed. Other things related to shear stress itself, once the opening of the lung, the blood gushes into the pulmonary vascular, flattening all those epithelial cells and cause vascular remodeling. In addition to other mechanisms that we're still trying to understand and fathom, so we can work on the better therapy and management. The problem is this process can actually be challenging, and it does not fully happen. And these babies will have a decreased pulmonary blood flow, resulting in hypoxemia, respiratory distress, and acidosis. And this can cascade is the hallmark and manifestation of the PPHN in newborns. So what's going on the endothelial cells of the pulmonary vascular bed? We have a couple of molecules. Some of them will facilitate vasodilatations and relaxation of the pulmonary bed, while other molecules act to antagonize this effect. Here, a quick example is the cyclic GMP that's driven at the end of the pathway of the nitric oxide, which is a naturally produced molecule in the endothelium. It facilitates a naturally vasodilating molecule. Similarly, cyclic AMP. On the other side, the myosin light chain and the endothelin receptors oppose these actions. And we will talk later about what therapy we have that target these molecules and these receptors. Babies who transition normal, they have no issues. The pulmonary vascular bed drop at least by 50% after birth, and you will have a natural release of nitric oxide, endogenous nitric oxide and prostaglandins, and they will have a good VQ mismatch and will be going through this transition very effectively. While babies who develop PPHN, for whatever reason, they will have the upper hand of the opposing nature of those vasoconstricting properties of the endothelial cells, and they will end up with VQ mismatch and right left to left shunting, resulting in severe hypoxemia and acidosis. This process, it's not only related or limited to the vascular bed, but also involves the lung itself as a cause or contributing factor to this process. And this is what we call a secondary cause of PPHN, as you see here listed conditions. And as we all know, the third party is the heart. And this is the problem that PPHN presents. It affects the heart and the lung, and those babies, as we all know, can be very sick and requiring ECMO at the end of the road. However, the right to left shunting is this what caused all this problem, and that would be the target of the neonatal therapy for neonatal PPHN. One of the other issues, the complication and how vicious the cycle these babies will go through. And as we all encounter, some babies will be very sick and you cannot get out of the cycle. No matter what you do, they will get sick either from the lung, the hypoxemia, the intractable acidosis, which reflects on the heart itself, causing myocardial depression, decreased coronary perfusion, and they go into vicious cycles. And even some of the medication that we use will take a role in this vicious cycle. So it's very important to choose the right medications in treating these babies. Some of the causes of the PPHN are reversible, and we all see them. And some babies have even mild forms of PPHN, like Down syndrome or so, and they will be in the nursery. Many of them we don't know about, but some other causes of PPHN are severe and intractable, and those are the ones who either die or need ECMO or have poor outcome. In the NICU, we have PPHN cannot manifest easily, and it can present and mimic other conditions like these conditions listed here. And it's very important for us to have the echo and proper recognition of these conditions should exist to differentiate between just straightforward PPHN without congenital heart disease. And they all share that the babies can become very hypoxemic and with the poor perfusion and shock. But what is the mechanism of the PPHN in babies? There are several proposed mechanisms. The number one is the maladaptations due to acute events, such as a result of perinatal asphyxia, sepsis, meconium aspiration, and we all encounter cases of meconium aspiration. They end up with severe cases of PPHN, and this is just an acute event, although it could be severe and intractable, and these babies can end up in ECMO. But the pulmonary vasculature itself has not changed or gone through modeling. When this happened, the modeling, these babies will have maldevelopment, and this remodeling, it happens because of there's another ongoing process within the lung itself, can cause the vessels to structurally change, and some of these cases are intractable, like the alveolar capillary dysplasia and malalignment of the pulmonary vessels, and some of these other conditions secondary to CDH and so on. Some of the other cases are related to hypoplasia of the pulmonary vessels, again, secondary to CDH, congenital diaphragmatic hernia, or other conditions like we see sometimes in premature babies who have oligohydramnios, and they can manifest as PPHN due to PPROM. And it could be simply, and less likely we see, due to obstruction from polycythemia and or other causes of vascular obstructions. What are the clinical features? It's very important to know what the underlying condition we're dealing with. Getting some of the history to set up the context is very important. We need to understand the delivery history and the birth history, or maternal conditions, even medication taken during pregnancy that can cause premature closure, for example, of the ductus. Even no medications. I came across a case that mom was taking some herbal tea, and that led to the premature closure of the ductus, and baby manifest with significant PPHN and premature closure of the ductus. The babies who are premature, they may not manifest immediately after birth, in contrast to full-term babies. And so we have to be watchful for this. Those babies will have labile hypoxemia, and they have differential cyanosis. As we all know, they may or may not have differential cyanosis. They may have some murmur and heave on cardiac exam. And as we know, if the X-ray is black, these babies will have black lungs due to idiopathic PPHN or secondary causes of PPHN, as we will see on the second slide. Some of us will do, if we're in doubt, they will do B and B to see if there is any elevation and can guide us further. But labile hypoxemia is very important. Sometimes we overlook this. But if you really see how these babies behave, you appreciate how labile these babies. The one time they will be okay, and the other time will be desaturating or even having a cyanosis. The differential cyanosis, it's not typically happen in all cases. It depends on the ductus, it depends on the shunt. If it's across the PFO, no necessary, wouldn't happen necessarily. But if it happens at the level of the PDA, those babies can manifest with differential cyanosis. Unfortunately, not all cases present per the textbook, and we have most of the cases present with mixed shunting and right to left shunting through the PDA and PFO. If we do X-rays, for example, as I mentioned, many cases have associated conditions, like this baby on the left has fluffy consolidations with atypical for meconium aspirations and very thick lung. This baby, for example, in the middle had similar meconium aspirations complicated by pneumothorax with the chest tube. All of them complicate the presentation of the PPHN. The baby on the right side has a black lung, not due to any parenchymal disease. If we put the pulse oximetry, like I mentioned, we can see differential diagnosis, cyanosis, but we all now calculate the OI to get a glimpse of what's going on, and based on that, we can categorize these babies' PPHN severity. And if you don't have arterial gas value, you can rely on the oxygen saturation index. And also this will guide you to when to use therapies. As we see here, low values less than 5 to 15, labeled as mild. Normal baby has OI less than 5. If it's more than that, you can start using surfactant if they are intubated. and so on. If this baby is approaching 15 to 20 of OI oxygenation index, and the equation is displayed here, and we all know it and we use it, then you can think of inhaled nitric oxide if it's available. And I came across one article that, and you correct me, Dr. Rajesh, and the group, that in India, 25% of NICUs have nitric oxide. I don't know how far or how this research, but I'm glad to hear that more nitric oxide is available in ICUs. Obviously, the threshold for ECMO goes around more than 50s of the OI. Another measurements is the AADO, which is the differences between the arterial and the alveolar oxygen concentrations. A simple formula is displayed here. Usually more than 600 is can consider significant and threshold for ECMO, in addition to OI of 40 and OSI of 16. This baby, one of our babies in the NICU, had a significant tricuspid regurg on the echo with a right ventricular systolic pressure of 65 to 70. As we see in the right side, the septum is flat, the right atrium is enlarged, and the left atrium, the right ventricle is also enlarged, and the baby has a significant tricuspid regurg, as we saw on the clip. Picture from the same baby. Here the tricuspid regurg depicted. It's 69 plus right atrial pressure will give us maybe a 74 millimeter mercury of right ventricular systolic pressure. You can also access, as we all know, tricuspid regurgite is not available all the time, and you may miss it in 1/3 of the cases. You try to look for it in different views and different tricks. You can look at also in the left long axis parasternal, and the baby has a similar TR jet. This baby also had predominantly right to left shunting, excuse me, through the PDA, and as well as predominantly right to left shunting through the PFO. So echo, as you clearly mentioned, is very important, and now it's handy, and it comes in different ways, and it's integrated in POCUS, or even handheld probes are available. So it's very important to have echo to help us diagnosing these conditions. And we have to evaluate the pulmonary artery pressure and the vascular resistance, looking at all these parameters. I'm not sure we all do all these parameters, but a couple of significant parameters can help us and guide us and aid us in the final diagnosis. But evaluating the pulmonary artery pressure and the vascular resistance, in addition to the myocardial function itself, is paramount in establishing a good case of Pphn to help us in the management. For example, a TR jet is very important, as we mentioned, and this is the equation based on the modified Bernoulli equation to help the RVSP, right ventricular systolic pressure, which is very important. And I think this is one of the most common measures that we take immediately once we suspect Pphn in our units, if we have echo handy, and we can, some of us can do it as an NPE, a neonatologist perform echo, or get the help with the cardiologist. Like we mentioned, 1/3 of the cases, the TR jet is not appreciable. So we have to try to look for other measures. PR jet, for example, is another way of doing it, but it's not easy to get, and it's a diastolic phenomena, and it gives us the mean and diastolic pulmonary artery pressure through this measurement. This is the how the flow, the CW flow look through the ductus, which is in here. It's predominantly right to left, as you depict here from the Doppler, and also the PFO shunting is right to left as depicted in the down picture. Another measurement is to look at the pulmonary artery acceleration time by itself in relation to the right ventricular ejection time. And it's a very good tool to look at the VTI, and from there you can evaluate these measurements. And a ratio of less than 0.23 is very significant, indicative of significant pulmonary hypertension. And it's very one of the measurements that it tells us how the pulmonary flow is going against high pressure or low pressure. The eccentricity index is also one of the available measurements that we can use. Basically, the left ventricle, you divide the longitudinal versus the transverse dimension of the left ventricle, D1 divided by D2, and usually in normal cases it should be around 1. If it's higher than that, you know that the septum will be flat, like in this lower right picture. It's actually bowing to the left side with a huge right ventricle and right atrium as well. And looking at the septal morphology, and you can give by eyeballing or by assessing how the septum look. It can give you also an estimate of the right side pressure. And for example, in the middle picture, you would estimate that the right side pressure is about 50 to 100% compared to the left side. And in severe pulmonary hypertension on the left side, for sure, the pulmonary, because of the bowing of the septum to the left side, the pulmonary pressure should be estimated to be higher than the systemic. Other measurements to evaluate and this is just examples, I'm not going to go through the full list, to evaluate the fractional area change of the right ventricle. And if it's less than 30%, as we see here from end-diastolic dimension into end-systolic area, and if it's less than 30%, you would know that the right ventricle is dysfunctional. Also, we all do TAPSE, and if it's less than 5 or so, you would indicate decreased systolic function in the right ventricle. Similarly, we do the ejection fraction and fraction shortening of the left ventricle. If you're going to do Simpson, you can method. It will help us evaluate the ejection fraction, and if it's less than 40, that's significant pulmonary hypertension. The TI index is another way if you're going to do the tissue Doppler, for example, and if the evaluating the IVRT and the contraction time divided by the whole ejection time, and if it's the ratio is more than 0.5, it would also indicate there is a significant pulmonary hypertension. So there are many measurements you can retrieve from the echo that help you and guide you, and you don't have to do all, but some of these would be enough. And the common one we use is just eyeballing, just as simple as eyeballing and measuring the TR-JIT. So how would we approach the cases of pulmonary hypertension? It's a multidisciplinary approach. We have to optimize the oxygenation and ventilation and evaluate the lung, and without forgetting the hemodynamic and the left ventricle function and the systemic blood pressures. We have to have a good balance between all of these to achieve the best strategy in treating those babies. In addition, obviously, we're going to use the medical therapy, which is the vasodilator therapy. We're going to go through this and hopefully we'll have some insights of what we do in our NICU. As we all know, oversaturation is not required, but those babies still need to saturate good, maybe a little bit more than what normal accepted saturations in most NICUs, but not much. But what should be avoided is hypoxemia. We need to support those babies very gently. We need to have decrease the lights and the sounds, approach very diligently. We need to pay attention to nutrition, approach caring for the baby, who's the best nurse and the physician to care for those babies. Do not mess up with those babies too much. Try to minimize handling and procedures, especially when the baby starts to recover. Often they receive antibiotics because of assumption of there's infection. Um, Usually they need some sort of sedation, and the choice of the medication it varies from one unit to the other unit. We do not routinely use paralysis, but it may be needed in some situation when there is a spike in the pulmonary pressure, or the baby is very agitated, and commonly happen, especially in big babies and post-term babies. So it can be achieved, but routine and continuous sedation, prolonged sedation, is not really recommended. As we all know, it increases the mortality. We used to keep those babies on the alkalotic side. We cannot achieve this anymore. But of course, we need to combat the acidosis, and PCO2 slightly high is okay, is acceptable, as long as the pH is not falling below 7.25. You can do this with some sodium bicarb, but it's not routine. It depends on case by case. Of those babies, ventilation, how to start ventilation, what sort of ventilation you start as a conventional versus high frequency. It depends on the NICU, but once those babies require very high pressure, have evidence of meconium, or using of inhaled nitric oxide, it's preferable to use gentle ventilation or high frequency ventilation. Some of these babies, like I mentioned, are in the nursery or the postnatal. They have some elements, but they're good, or they need NICU admissions, but they have a mild form of respiratory distress and Pphn if echo is done. And they just need the CPAP 6 to 8, and they can be managed conservatively and with some supplemental oxygen, as long as the lung is taken care of and well inflated. However, most of these babies, as we all know, they need intubation and prolonged mechanical ventilation, actually, relative to their illness. The criteria of intubation vary from NICU to NICU. Some would use 50% or 60%, but the goal is to keep normal pH more than 7.25, and as I mentioned, a CO2 target of 45 to 60. Surfactant is a controversial topic in these cases. Some of us are not comfortable giving surfactant, but if you want to improve the compliance, especially in those babies who are late preterm infants, infant of diabetic moms, have pneumonia, or even meconium, surfactant, I think it's reasonable to give surfactant and consider giving surfactant. You may give it with precaution, because those babies may react badly to the surfactant while you're giving it. And we've seen some cases that really deteriorate after giving surfactant. As I mentioned, once the parameters are escalating, especially if you're going up on the PIP over 25 to 28, and the baby is not responding to the conventional ventilation, whatever type you're using, you may consider high frequency oscillations or jet. If you have, no one has no jet except the US. They need oxygen, as I mentioned, but avoid 100% oxygen because of the toxicity, and it's counterproductive because it will eventually lead to increased oxygen species and free radicals and endothelial damage. and it will worsen the pulmonary hypertension itself. Our goal, as I mentioned, is to have saturations 90 to 97, maybe 95 to 97, and the PO2 50 to 80. Below that, as we all know, the pulmonary vascular bed react badly, and they can end up with vasoconstriction, hyperoxemia also lead to the same issue. So what other therapy we have, choices of therapy we have available? The best of all and the readily available is inhaled nitric oxide, which mimics the natural process of NO release inside the endothelial cells. So we will talk about this and other medications like merolenone and sildenafil. I know it's widely used in areas and regions in the world where nitric oxide is not available, and some other adjuvant therapies like Pozintan and prostaglandin analogs are being used somewhere as well. As we mentioned, nitric oxide is a naturally occurring molecule, and once we give it, it will go through the endothelium, and it spreads into the vascular bed and immediately takes its action within seconds. It works on the cycle, increasing the cyclic GMP, which has a very major vasodilator role and cause immediate relaxation of the pulmonary vessels. However, do we routinely use nitric oxide? There are some precautions we have to take before using nitric oxide. We need to understand the baby. We need to make sure we're not dealing with significant case of congenital heart disease. So echo is very important, but we still can try nitric oxide until we have official echo or very detailed study of the baby, or we can entertain these diagnoses if the baby does not really respond well to nitric oxide. We have to also assure that the left ventricle is functioning well to prevent pulmonary edema and pulmonary venous congestion, which can manifest as also PPHN. Babies who have left ventricular dysfunctions are listed here, like babies who have congenital diaphragmatic hernia, asphyxia, sepsis, and post-cardiac arrest. But in those cases, merolenone could be also another option until you fix the left ventricular function. So we have to be very diligent, know our babies. Some of us would use nitric oxide empirically, and some protocols have mentioned that if you don't have echo and you see the response and how is the baby doing, and based on that you would de-escalate or get an echo assessment later. If there is congenital methemoglobinemia, those babies who presents with high level of methemoglobin, 20 to 25 and above, of course nitric oxide is contraindicated, and we have to ensure treatment with different therapy. Probably different units have thresholds when to use nitric oxide. Earlier, better, and some advocates for values of OI 15, but most of us will use it at a value of 20. Anyway, 15 to 20 is important, and it's very important to consider surfactant, because the first thing that comes up in our mind is nitric oxide. But surfactant is still there and can do some job. And studies have shown that it reduces ECMO, independently reduces ECMO use and death. We can start at 20 ppm unless your protocol states differently in a smaller baby, less than 34 weeks. In our unit, we use 20 ppm in also small babies. Some units restrict inhaled nitric oxide to 10 or even 5 ppm in premature babies. And there is a rule of 20. You start with 20 ppm, you wait for 20 minutes to see if there is a response. and then you start weaning, or unless you see side effects. Um, and those basically there is no major contraindication of nitric oxide unless those we mentioned previously of left ventricular dysfunction, congenital heart disease, methaemoglobinemia. But there are some concerns about bleeding, if the baby has active bleeding, especially in premature babies, um, and or low platelet dysfunction. Some studies, but only in vitro, um, have shown this deleterious effect of nitric oxide in those babies. Um, and maybe in some situation, if you're dealing with an extremely preterm with oligohydramnios and PPROM and the suspected lung hypoplasia, you have to balance the benefits and the use of nitric oxide. You may delay use of nitric oxide after 24 hours, but most of the cases, no significant bleeding happen. Um, uh, as we mentioned, those babies, if we once they respond to nitric oxide, they usually need nitric oxide for a couple of days. Try not to drag on nitric oxide and be proactive. Once you reach maybe FiO2 to 60, some units use 50%, or PO2, if you have arterial line more than 60 for 60 minutes, the rule of 60, then you can start weaning nitric oxide. All of us use different protocol. But the process of weaning is you win until you reach a goal of 5, whether you win significantly from 20 to 10 to 5, or you win by a couple of ppms every couple of hours until you reach 5. But then you win by 1 ppm every 2 to 4 hours until you reach until you stop it. However, stopping it can cause significant rebound, and you usually need to increase the FiO2 when you reach 2 to 1 before stopping it. And some of these babies will have really rebound hypertension. So it's very, very important that from 5 ppm until you stop nitric oxide, be very careful and go slowly. The nitric oxide is, as Dr. Rajesh mentioned, it's the becomes widely available. Many units now acquire nitric oxide because this is the only medication that's proven to be effective in cases of PPHN. All other medication are adjuncts or supplementary. It's been shown to improve oxygenation and reduce the need for ECMO, and improve the outcome, the pulmonary outcome, but does not really affect the mortality or long-term morbidity. And many babies are not responders. 30 to 40%, they are labeled as non-responders. Nitric oxide is a local medication and works on the lung only for the most part, and does not affect the cardiac function. And actually, it can worsen if in those listed conditions. So anything else is an add-on medicine, and we'll go through this quickly. What happens if you fail to control PPHN with nitric oxide? You need to revisit the management plan. You need to optimize the mean airway pressure. Some of these babies will need, if they have homogeneous lung, you need to recruit the lung as well and give surfactant. You need to escalate maybe to gentler ventilation. Some babies respond, although some units have better experience with conventional. It's better to use, forgot to mention, to use the volume targeted ventilations versus pressure. Some units and some PQs I've seen, they have good mastery of using the pressure targeted ventilation, and they have good results. But as a neonatologist, I rarely do that. We need to also reevaluate, repeat echo measurements to see what's going on. Maybe the heart is now dysfunctional, right side or left side. Maybe you need to be aware of the TAPVR, total anomalous pulmonary venous drainage. This condition can mimic PPHN, especially if you have right to left shunting across the PFO, very important. And these cases are sick. Those babies can be very sick if they manifest in such a way, and they need to have surgical correction and move to an ECMO center. And also, you need to maintain a good systemic blood pressure. We used to increase the systemic blood pressure above the pulmonary measured pulmonary pressure. We don't do this anymore, and because it can compound the problem and can manifest as increasing after load to the left ventricle, and it can worsen the left ventricular dysfunction. Um, a reasonable blood pressure is okay as long as you avoid hypotension, and those babies often require vasopressors, and we'll talk about that. If you fail to control the PPHN, then you can add with the nitric oxide, then you can add supplementary medication, second line. In this case is milrinone and sildenafil, or even you can add adjunct medications. It depends on the center. Or consider ECMO. We encourage to call ECMO center early if you don't have ECMO on site. So at least you have a dialogue with them, and then should the baby be transferred before getting sicker. And some babies wouldn't make it actually to an ECMO center. You have to think also of rare conditions that can cause significant PPHN intractable and need ECMO for sure. This list is a common medication that used in management of PPHN targeting the pulmonary vascular bed. Like we mentioned, it's nitric oxide is the most studied based on RCTs and consensus, while sildenafil and other medications shown some significant value in small RCTs and case series. Still, research is urgently needed to evaluate these medications, including Pozintan and milrinone and other prostaglandin analogs. Very important because we still lack medical management of PPHN, and many of these babies would die. So research is very encouraged. And I have not this slide, but I have another slide. There are ongoing research, translational research on animal models, working on many molecules that hopefully will help us manage these cases in the near future. Steroid also have been evaluated, and it's always supplementary medication to use, and we'll discuss this in the next slide. Milrinone, for example, I'm going to just go quickly for the sake of the time over these medications, is phosphodiesterase 3 inhibitor, which increases the cyclic AMP, decreases the pulmonary vascular resistance. It's considered as an inotropy and lusitropy because it enhances the relaxation of the myocardium. It's a very nice medication, and it's commonly used in those babies who have PPHN and myocardial dysfunction. It's always used in synergy as a second line with milrinone. With inhaled nitric oxide. However, the babies who have HIE, for example, we need to be aware of their risk of excreting milrinone, and it's rarely used, but it in clinical practice has been used, but you may use a small amount. We rarely go beyond 0.75 microgram per kilo. Some units can go up to 1, as long as you know the side effect. The most of all will be risk of hypotension. That's why we do not use a bolus when we use milrinone. We just give the medicine as an infusion. So just be aware of the renal accumulation in case of HIE. Sildenafil, and I'm sure it's been used in India a lot. There is a lot of case reports and studies and RCTs. But in general, randomized control trials are very difficult, and if it's done, it's very small number. It's not easy to do an RCT in such condition. So it's a very challenging condition, even in seeking medications through research. Uh, Sildenafil is a PDE5 inhibitor, and it causes significant pulmonary vasodilations. It can be used as an IV after loading, up to 1.6 milligram per kilo per day, up to 2 milligram per kilo per day as a continuous infusion. If it's given orally, the bioavailability is less. The dose is a little bit higher, but can be given Q6 or Q8. Sildenafil itself reduces mortality, but not in those cases that ECMO and nitric oxide has been used. And it works well in those cases where there is significant hyperoxia, because hyperoxia would upgrade the PDE5 receptor, and it makes it suitable for sildenafil to work. We also, one of the side effects of sildenafil, in addition to hypotension, it wouldn't cause liver damage, but it's because it's secreted through the liver. So if you have liver affected, then we have to be careful and of the sildenafil effect. Pozintan is another medication usually used as an adjunct, not a second line. It's a dual blockage of the endothelin receptors, and it's only available in oral form. It's used mainly in older children and also neonates, off label, obviously. It works good in cases of remodeled pulmonary vasculature. There is limited evidence, like I mentioned, only case reports and small RCTs. And when those cases are done, usually compare Pozintan to or even sildenafil, in that matter, to placebo. So RCTs with head-to-head comparison are very needed in these cases. We have to be careful of the effect on the liver. The prostaglandin analogs, I'm not sure how commonly is used in India, but there are forms mainly used in older babies and in the peds ICU. They can come in different forms. Inhalation, IV, but significant, or even patches, skin patches. But the main side effects of these medications is significant hypotension, but can be used as a last resort in some situations if ECMO is not available. Like I mentioned earlier, those babies often need inotropes and vasopressors, and very important to choose the right medication. And I've seen all types of medication being used, not knowing exactly what's going on with the heart and what is the effect of the medicine on the lung itself. But norepinephrine is predominantly, as you all know, alpha, and it does not affect doesn't have a chronotropy on the heart itself. So it's a good vasopressor medication with limited effect on the heart, which is very important to avoid the tachycardia and the increased oxygen consumption of the myocytes, and as a result of epinephrine or dopamine for sure. It's a very common medication to use, and if the heart itself is good and functioning well, so we can use norepinephrine. Usually start with a small dose, um, and titrate up. We don't go very high on on the doses. We try to avoid significant vasoconstriction. That will, like I mentioned, unnecessarily increasing the blood pressure, systolic blood pressures, and impedes the afterload and worsen the cardiac function. Epinephrine, it can be used, but usually we use the small dose, 0.1 microgram per kilogram per minute, if the heart is affected. So it increases the contractility of the heart, and also can have, but with this dose, it's limited to the heart. If you go up on the dose, it might affect vascular resistance, systemic vascular resistance as well. But the problem with it, as I mentioned, it can cause significant tachycardia, and it can these patients can have develop acidosis and lactic acidosis and hyperglycemia, and it just can get worse. So try to limit the use it to 0.1 microgram per kilo per minute. Hydrocortisol can actually help those babies, especially if they have sepsis, and improve the blood pressure. And it can, in some animal models, can affect the response to nitric oxide. 1 to 2 milligram per kilogram per dose Q8 hours can be used until you have the desired effect. Milrinone, as we mentioned, is very commonly used as a second line or in conjunction with the inhaled nitric oxide. And we just have to be aware of the hypotension that causes it and the risk in HIE cases. Vasopressin is an emerging medication, and I'm not sure how common this medication is being used in India. We have some experience in using it. It's beautiful medication. It has no effect, obviously, on the pulmonary vascular bed, and as a matter of fact, it has pulmonary vasodilator effect as opposed to the other medications, particularly dopamine. So it has dual effect, and it's purely affect the systemic vasculature. So you're not unless you have left ventricular dysfunction, you need to be aware of the effects of the afterload increase. But it's a good medication. You start with a small dose, and then you titrate up, and you watch the water balance, and those babies can have a significant hyponatremia, and this is the common use of discontinuing this medication in those cases. Not much studies found in vasopressin. We try to retrospectively collect some cases, but it's very, very challenging because it's not solely used. It's used in conjunction with other medication. Dopamine, I'm not sure what's your experience with dopamine, but it's fallen out of favor because of the bad effects that we mentioned, especially the effect on the pulmonary vasculature and the unpredictable effect on the afterload and systemic blood pressure. So try really not to use it. If used, we just use a small dose, maybe 7.5 maximum to 10. In addition to its bad effects on the endocrine system and the oxygenation, oxygen consumption. Tachycardia is the enemy of the heart in these cases, and dopamine for sure causes tachycardia, and we need to avoid that. Dobutamine, especially in cases of HIE, it can be used. It's an inotropic medication, increased contractility. The problem is it decreases systemic vascular resistance. But in HIE cases, the systemic vascular resistance is on the higher side anyway. So it can be used in conjunction with other medication as well, like low-dose AP or vasopressin, or until you buy some time to understand the case itself. Like we mentioned, avoid increasing the blood pressure above systemic values because it has its bad effect and downside. Our goal is not to reverse the shunt on the PFO and the ductus, because these are pop-off valves and very important to keep it open. Our goal actually would rather be to decrease the pulmonary vascular pressure. That's why nitric oxide is the ultimate medication to go, because it targets and shortly the pulmonary vascular bed, and it avoids any other systemic effects. A genius medication. ECMO, most of the units have criteria for ECMO, but of course, if the baby is not improving, as we mentioned early, or having an increasing hypoxemia for a period of time, we need to contact the ECMO center, and we transfer this baby early. And this also give us some the baby chance for survival, which reaches up to 60 or 70% on babies with PPHN who receives ECMO. This is the conclusion of my talk, and I want to emphasize that PPHN is a failure of normal transition, and it's a very challenging condition. Echo has a major role in diagnosing these conditions, and not only one echo, but a serial echoes to understand what's going on, especially the cardiac function, how it responds in the to the medical treatment, and orchestrate further escalation of the management. We need to target the lung, the vascular system, and the heart as well. Keep in mind, if you have to invest, you need to invest in having an inhaled nitric oxide in your NICU, and recognizing these babies is very important. Do not mess up with these babies. Do not do procedure. Once I hear hypoxemia, especially in postnatal, I bring the baby close observation and see what's going on. Some of these babies actually can manifest as failing CHD screening, congenital screening for congenital heart, cyanotic congenital heart disease, and they will come down and we'll find out that they have some elements of PPHN, whether due to sepsis or other conditions. So it's very important to recognize these babies to prevent significant morbidity and mortality. Thank you very much.
Oh, thank you, Dr. Ashraf. And that was a
Thank you.
very good presentation. And only a few points I will just make it